Hey, everybody. Before we get to the show, I wanted to thank those of you who've joined us on Patreon to become members of our Patreon community. It's so great to have so many of you from all over the world. Andrea, one of the perks of the Patreon community membership is a monthly Zoom call. Tell us more about
Yep.
that.
You get a Zoom call every second and third Thursday. So that's with the three of us on the second and third Thursday of the month.
And Dr. Cooper, two different levels. So the second Thursday of the month is for one level, the third Thursday of the month is for the other level. Tell us more about the different levels on Patreon and what those mean.
Yes. One of the levels is for the general public, our regular listeners, and it'll be a live Q&A. Bring your questions, and we'll try to answer as many as we possibly can. And the other level, the higher level, is for, we call it Pro. It's for healthcare professionals. And the general public's welcome to join that one. But it will be answering more technical questions, probably, in that live Zoom call.
And I feel like the importance of this is that the discussions that are taking place more frequently now between patients and providers are so important for guaranteeing, a good treatment and a good addressing of the issue of metabolic dysfunction. There's power in community. So we just wanted to say thanks, everybody, for joining us on Patreon. All right, let's get to the show. Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. Always good to see you two.
Good to see you too.
Hello.
All right, on the show this week, we are ripping the headlines. My early job in journalism, I was a part-time board operator in Spokane, Washington. So I would punch buttons at the radio station to keep the programming on the air overnight. And one of my jobs was to rip the Associated Press copy as it came off the printer and put it on the appropriate peg in the newsroom. Sports over here and headlines here. And so we are literally ripping the headlines when it comes to GLP-1s. A number of interesting developments have happened this month, the month of December, when it comes to GLP-1s. And we're going to break down those headlines and talk about why it's relevant and why it's interesting, because I don't think we can find out enough about GLP-1s. The thing that first caught my eye, Dr. Cooper, was for the first time in history, the World Health Organization has issued guidelines recommending the use of drugs, GLP-1 specifically, to treat obesity. And I mean, what year is it? I'm thinking hasn't this already happened? But I'd like to start with just the significance of the WHO's role in healthcare around the world and why this is a big deal.
Yeah, it really is a big deal because the World Health Organization, they were actually the first to claim that obesity is a disease. And that was actually in 1948. If you can believe that. Mm-hmm. That was way before anyone else did. But then they went on to frame it in the sense of like epidemic analysis and that kind of thing around the world later in the 1990s. But they didn't really go into treatment, any kind of treatment recommendations. And what's kind of interesting is the American College of Clinical Endocrinologists and Endocrine Society, I think, were the first to put out guidelines in it might have been 2015, 2016, that said the use of pharmacology is recommended above and beyond not using pharmacology in obesity, so that the pharmacologic approach should be the standard of care in obesity. This was a decade ago. And now finally the World Health Organization is saying something kind of similar, and have to give a hand to Canada because the Canadian Medical Association came out also in 2020 saying pharmacology should be part of the treatment too. So the American Medical Association first, then the Canadian, and now the World Health Organization finally is coming out and putting the pharmacology in the spotlight, and they're focusing on GLP-1, the GLP-1 class. And maybe the reason is that they're hoping to do something to make that class more accessible throughout the world.
So we've got 5 reasons that this is a big deal, the WHO recognizing this. First up, the first reason is that it officially recognizes obesity as a chronic relapsing disease and not a willpower issue. We've talked about this, Dr. Cooper, so many times on this podcast that doctors even today are still saying, eat less, exercise more. This is the world's foremost medical governing body saying that's not true, and it's a medical condition that requires a medical treatment, right?
It is, yes, and that it requires that long-term, because it's a chronic disease that requires long-term treatment. I mean, I think as long as people believe that it's a behavioral problem that people can solve on their own, it becomes more convenient to the healthcare societies to just turn their back on it and just push that responsibility onto patients to solve on their own through supposedly, altering their lifestyle or their behavior. And so now I think with the World Health Organization coming out so strongly saying that's not acceptable any longer, hopefully this will reverberate around the world.
Number 2, it's endorsing long-term use of GLP-1s and not short-term dieting. And I think that's a really big deal because the long-term versus short-term is a big deal.
Yeah. And I think that's something that people still are trying to get their head around, the fact that, well, why can't I just take this medicine and just be done with it? Then, the medicine will help me get to a, quote, healthier weight, and then I could stop the medicine. And we just know that's just not the way it is, because since it's not a behavioral problem, it's a physiological problem that's triggered by, in most cases, genetic predisposition, then, how are we going to get to a point where you can stop that medication and not have the return of the problems that caused the high weight in the first place? So I think this is an awareness now that's kind of catching on, that this is meant to be long-term treatment. And by them stating this is going to help with treatment coverage over the long term, because otherwise insurers or people who are responsible for covering the costs of these will just assume we're going to, provide this for a short term, and then that should have taken care of your problem. And this is saying no. Even when the body weight is returned back to like a normal level, the coverage should continue, the treatment should continue beyond that.
That's really interesting, Dr. Cooper, because I talk to people all the time. My neighbor, every once in a while will drive by and he'll pull over and we'll have a chit chat. I talk to so many people who are worried about having to take GLP-1s long term. They're like, well, but I'm really concerned that I might have to, take this for the rest of my life. And I get that, and there may be some concern with other drugs, but like we're all on medications like for blood pressure and for cholesterol and for, fill in the blank. And we're going to have to take those for the rest of our life if we want to keep those levels optimal. So is that something that you see as sort of a bias against GLP-1s? That, it's not just a one and done, we have to keep taking it?
Yeah, I mean, I think it is on, as you said, medications in general. I think people feel almost a shame around having to take medication and thinking that they failed somehow because they need to take these medications and dependent on them. But I keep reminding people, this medication is keeping you healthier. You're actually healthier because you're on this medication. This is not dangerous. It's not putting you at risk. It's actually reducing your risk. So it's reframing in your mind, what that medication is actually doing. Of course, you want to make sure it is safe, because some people, it's not the right thing for them to be taking. And so it's not that everybody needs to go on the GLP-1s. And I know the World Health Organization made this all about GLP-1s, which is fine, but there are other tools in the toolbox besides GLP-1s for people that are struggling with obesity. So if people can't take the GLP-1 because they can't, they may have side effects, they can't tolerate it, or they have a medical condition that makes it so they can't take it, or they can't get access to it. There are other strategies besides the GLP-1, other pharmacological strategies, but the World Health Organization didn't really mention those. I think one of the reasons is they see that the GLP-1 access is really threatened, while some of the other pharmacological tools are not, because they're generically available. And so I think they're trying to really push for an increased access to the GLP-1 meds.
Yeah, we'll get to access in
Yeah.
just a sec. That's
On
a
the
big one.
long-term thing, though, I always tell people your metabolism is like a lifelong issue. It's not a headache.
Yeah.
Yeah.
Yeah, for sure. We're breaking down the top 5 reasons that the WHO designation is a big deal. Number 3, it emphasizes GLP-1s have to be paired with intensive behavioral therapy and metabolic care, not just
Not
used
alone.
alone. I can't count the number of times, Dr. Cooper, that you've talked about the importance of nutrition, lifestyle, fueling. Talk about that, if you would, that it needs to be paired, not just, well, we've
Yeah.
talked about how some of these drugs are just sort of written
Yeah.
over the internet, but what's the importance of that pairing with behavioral therapy?
Yeah,
And
I mean, I think that's what really makes sense, to have a provider who really knows your whole health history and knows your social history, your lifestyle, and can help with a supportive lifestyle for your metabolism, metabolic health. And so when we talk about that, we're talking about sleep habits, what time you go to sleep, the quality of your sleep, what time you wake up in the morning, your eating habits, how consistent are you with fueling your body throughout the day? Are you getting all the food groups? Are you getting all the nutrients that you need? And if you're ready to introduce exercise, are you fueling that exercise? Are you exercising in intensity ranges and modalities that are actually going to be most beneficial for your health and your metabolic profile? So I think it's trying to look at that. Now, the danger in it is it can kind of harkens back to the old school thinking of this is behavioral, a behavioral problem. So you're doing something wrong, you're eating too much, you're eating the wrong things. But that would be somebody's taking what the World Health Organization is saying and changing the meaning and putting it into that old framework. So we want to, anytime we talk about nutritional strategies or behavioral strategies, we want to keep focusing on metabolic health, not deprivation, not thinking that we're referring to a diet as a nutrition plan. We're not talking about underfueled exercise. So when we see the word behavioral, it kind of, it does make me have a little bit of bristles because of just the connotations from the past. But let's move away from that and recognize that our behavior does matter, but we're flipping it around. Again, reframing from deprivation to fueling. That's the goal. We don't want to be deprived. We want to be fueling from adequate, getting great sleep, not, working all day, all night, and being on your phone until the late hours. And we're focusing on, yes, exercise, but fueling the exercise, fueled exercise. So it's a different mindset when we talk about behavior for metabolic health than what the old school, used to tell us.
Right. And what I thought was also good on here is that they warned about the inequity for a lot of the GLP-1s, about how a lot of the world can't afford a lot of the drugs. And they talked about how maybe 90% of the obesity patients would not have access to a lot of these drugs.
Yes. And that's unfortunate. And, it's been a chronic problem. When I first got into this field, we actually had really good access, which is kind of a funny thing to think about. But it was mainly because it really wasn't on people's radar.
Yeah.
And so
Follow the
obviously,
money.
obviously the insurers, weren't really focused on limiting access at that point. But as there's been a wider spread use of this class of medications, we've seen reduction in access. And now they're trying to aim for an expansion again, which I think it's going to be tough. But luckily, I think there will be some avenues in the near future for greater expansion of access.
Yeah.
All right. the number 5 reason that this is a big deal. It signals governments and health systems that GLP-1 coverage should be considered, not treated as cosmetics. So do you think this designation by the WHO, Dr. Cooper, will help kind of open the door a little further to uniform coverage by governments and health systems?
Well, I think some of what they said, what they're trying to do there is because the access may be limited, it's selecting the patients that really need these drugs the most is what they want us to be focused on. And so I think that's going to be looking at the patient populations with more comorbidities, that stand to have big health issues if they don't get access to this treatment, not just mildly elevated body weight. And so I think that it's that I think once you get into that mindset, then you can see that, okay, we're not using this medicine as a cosmetic treatment. We're not seeing true metabolic dysfunction as a cosmetic condition. We're seeing it as a health condition. And so I do think that should help, but I'll tell you one little quick story. In the United States, a while back, this was, I believe, shortly after the guidelines in the US came out for clinical treatment, back in like about a decade ago, there was a legislative publication that said that it's no longer acceptable to view obesity as a cosmetic condition in people in the military. So this was by the federal government, came out saying that you must cover treatment for obesity for people in the military. And so this is like TRICARE in our country. But yet we'd write prescriptions and they'd get denied. And so we had to include that copy of that legislative letter that was like, I don't know what it was, but it was an official statement. And once we included that, we could push for coverage for that group. But now they've pulled that coverage away again. And you can't even find that original letter anywhere. So even though they're saying this, don't consider it as a cosmetic condition, consider it as a medical condition, we don't know how far that's really going to go or how well that will take, whether people will really get their head around that just because the World Health Organization is saying this. I mean, I think it's great that they are, and I think more people need to say that too. More of these groups in each country, their healthcare organizations need to say it, and all of their government-sponsored healthcare should say it. For sure, the military should be covered. Our school teachers should be covered. All of that. So hopefully it will open the door to more expanded coverage.
Well, here's a disappointing fact. My state, which California, which is usually so good about things and covering things, Medi-Cal just said that they're going to drop GLP-1 coverage for weight loss. And it's just so disappointing that California's Medicaid program, which is Medi-Cal, they just said that they're going to drop coverage for it starting January 1st. So, like Wegovy, Saxenda, Zepbound is not going to be covered for weight loss, except for type 2 diabetes, unless very strict guidelines are met. Even though the WHO said that obesity is a chronic disease and it indicates for medical treatment, they're still not going to cover it under your insurance. It's terrible.
Yeah, that's really too bad. I'm wondering what's driving that. I mean,
don't
obviously it's
know.
financial,
I
but
would
I think,
say it's probably some lobbying organization.
well, it's probably financial just because the cost can just overburden the healthcare system at the current costs. But when we think about it, the cost of not covering, especially in that population that has less access to high quality medical care, the cost of not covering it is probably way higher because you're going to have more cardiovascular events, you're going to have more diabetes. And once you get full-blown diabetes, the costs just skyrocket. Because now you've got complications with kidney disease, eye disease, potential vascular
Hospitalizations.
amputations.
All those
neuropathy.
hospitalizations
Right. And
would
then,
cost so much more
yeah.
than fixing the
And
problem in the beginning.
yeah, and then it can also pull people out of the workforce. So, I think that
It seems
and
penny-wise and pound foolish to
yeah,
me.
it'll end up keeping them on the Medi-Cal system longer because of health complications. So, whereas if you would cover it, yes, it's a big outlay, but negotiating with the drug companies, I mean, maybe I'm sure that's what it is, and they've probably run the numbers, and they still think that it's less expensive to not cover it. But I'd find
I
that
don't
hard to believe.
I find that very difficult to believe that you couldn't get a batch deal on something. It just doesn't make sense to me.
Yeah, Dr. Cooper, do you think that more people in California will be turning to sort of unsanctioned online providers of these drugs because of this? Because it seems like a big shift away from coverage to nothing, that these patients are going to be looking for some sort of relief.
Yeah, but I think the people on the Medi-Cal, I don't think that they'll even be able to afford the online because the online
No.
options are still expensive. I mean, they're only a little bit less expensive now than the brand name.
Right.
And so they may turn to it, but they wouldn't be able to probably sustain the cost if they're already on Medi-Cal and they qualify for Medi-Cal. So I think it's just squeezing them out of treatment, and I don't
Right.
think
It's
it's.
still that's still $300 a month, for the like Hims, hers,
Hmm.
or
Well, they
whatever.
can be less than that, but it's
Really?
still, yeah, they can be less than that, but it still adds up. And yeah, and so I don't know. I think they will use the healthcare system more under the Medi-Cal
For
coverage
being sick.
for being sick and maybe even ER visits, hospitalizations, and things like that. But that's where people have run the numbers, I'm sure, and they are convinced themselves that they're saving money doing it this way.
All right, let's break down story number 3, GLP-1s in the headlines. So this is GLP-1s and the brain. There's been an Alzheimer's setback versus addiction hype. We're going to break down what happened. First, 2 big randomized trials of oral semaglutide, which is Rybelsus, in early Alzheimer's patients. There were about 3,800 patients, failed to show any slowing in cognitive decline versus a placebo. Researchers called the results stone cold negative, and Novo Nordisk is now discontinuing those Alzheimer specific trials. And at the same time, new coverage in Nature highlights ongoing trials using GLP-1s to treat addictions, specifically smoking, alcohol, opioids, by dampening dopamine-driven cravings. So, Dr. Cooper, this is 2 big developments. Were you surprised by the Alzheimer's study?
I wasn't sure what to expect, but I've seen mixed reviews over the years with the Alzheimer's studies, the preliminary ones. One thing that is interesting, this group that they looked at, it was a mixture of people. Some had metabolic problems and some did not. They didn't exclude people based on their weight or their glucose level. So some had normal glucose, some had elevated glucose, some had normal weights, some had elevated. So it was a real mixed group. To get in, you had to have, I guess, mild Alzheimer's, and then they monitored for the decline, cognitive decline, and they did not see any benefit. But if you look back in I believe it was 2017, 18, 19, liraglutide was tested and in a trial. And liraglutide is Victoza, Saxenda. And that one, because there were early animal studies that showed reduction in cognitive decline associated with aging with liraglutide. And so that trial showed what looked like some mild benefits. It wasn't like a drug trial that was trying to get FDA indication for it. It was just a trial that was implemented to look at the results after these animal studies showed some potential promising effect. And they did see some favorable MRI changes and some favorable impact, although it might have been mild. And so I think we're probably not done with looking at this group of meds. Liraglutide is different than semaglutide. And liraglutide often would boast that it was the most bioidentical GLP-1. And so they postulated that it could penetrate the brain better than the others, but we don't know if that's really true. But you never know. There may be more studies with maybe liraglutide in the future, or some other peptides that are in the same kind of group of medications, and we may see something different. But for now, we can feel like, okay, that is not going to be of benefit. But you have to step back from that for a minute, because that's Alzheimer's. But when we think about dementia, the most common cause of dementia would be multi-infarct dementia, which is just vascular problems related to high blood pressure, cholesterol, general health, diabetes. And so when it comes to that group, for sure the GLP-1s would, reduce the risk of all of those kinds of complications over time, just logically, because they're improving our cardiometabolic profile, our glucose levels, and things like that. So, but this particular Alzheimer's, it doesn't show any kind of benefit.
So this is interesting. On the flip side, we've been tracking this for a while. These early studies that GLP-1s may have a positive impact when it comes to treating addiction, alcohol, nicotine, even opioid, by turning down cravings. This is really interesting, Dr. Cooper. And, we're early on, but it seems like the early indication is that this may actually have a benefit. Do we know why that is?
Well, I think that this has been a category of med, like any of these anti-obesity medications, a lot of them have been shown to have crossover effect on drug or alcohol cravings, and even nicotine. And so when you think about it, bupropion, which is used for obesity treatment, has been used also for smoking cessation. And when you look at naltrexone has been used for preventing alcohol relapses for people with alcohol use disorder. And these are all meds that have been used in metabolism. And there is a part of our metabolic pathway that we talk about a lot. It's the POMC. And that is where we produce our own endorphins and our own amphetamines and our own drugs that make us feel.
The internal drug factory.
Yeah, it's our internal drug factory. And that's a huge part of our metabolic pathway. So you would think anything that improves the function of that pathway may have, a side effect of helping us reduce our reliance on outside substances that make us feel a certain way.
Wow, that's interesting. We'll have to keep tracking that.
Mm-hmm.
I was in touch with one of the researchers back in Oklahoma. We'll have to reach back out and see if they're ready. I think they have enough data now to talk with some confidence about that connection between GLP-1s and addiction. All right.
Story number 4. There, in India, Ozempic is launching, which is going to be huge because
That's a
they
big
do have
deal.
a problem there.
Yeah.
And so Novo Nordisk is going to launch Ozempic in India. And it's interesting, though, because Eli Lilly's Mounjaro is already a very big seller.
Mm-hmm. That's right. And I read about that too. And it's really interesting. It's that apparently Novo Nordisk didn't really, even though they had the patent for Ozempic, I don't think they launched it until fairly recently in India. But due to their patent is about to expire in 2026, and so the generics are already gearing up to replace the brand name, or at least to offer an alternative to the brand name in India. And due to the patent structures, they already have approval to start manufacturing the generics. And so I think that sounds like it may be like a big breakthrough in India to have generic semaglutide available, and it should be pretty soon. So it'll be interesting to see what the price point is on that.
we're talking
Wonder if
about a
that'll
country with
affect.
almost like 1.5 billion people. There's been a lot of talk, Dr. Cooper. I mean, commodities markets across the world are closely watched because they're a huge economic driver. And there's some concern that there may be a massive drop off of sugar consumption when you expand GLP-1s into a country of almost 1.5 billion people. Has there been talk? I mean, I've heard rumblings of stories about people eating less junk food and stuff like that because of GLP-1s, but has anybody actually studied that, I wonder?
I think they have. I think they have shown. I don't quote me on it because I haven't looked at it recently, but I did see some little blurbs in the scientific community stating that there's beginning to be a shift in reduction of consumer uptake of like quote ultra processed foods in general, and it's just some of this is kind of breaking through, I think. But again, you're going to see a lot of discrepancy based on socioeconomic status because a lot of these foods are less expensive and they are more calorie dense. And so people will gravitate to that if they're economically strained.
I wonder what it'll mean about generic GLP-1s.
Ooh.
That's my more, I think that's going to be very interesting because once India starts creating a generic GLP-1, I wonder what that will do on the global market.
Yeah, because we've already got generic Victoza,
Right.
liraglutide, and generic Saxenda, which is liraglutide. And those have been out now. And there's several, I think, several manufacturers competing there. And I think I don't really understand how the patents go in other
I don't,
countries,
yeah.
but from what I've heard, Novo Nordisk is also losing their patent. Maybe it's misinformation, but their patent in Canada for Ozempic also. And
Interesting.
so that may facilitate more generic competition for the semaglutide. And so
Yeah.
if we've got India and then some other, I'm sure this is one like major generic manufacturer that's going to be making the semaglutide for India. So there'll be others, I'm sure, that jump in and will compete. And so that competition will bring the price down over time. Usually when these generics are launched, the price point is very disappointing. It's not much different than the brand name usually.
Oh,
Yeah,
interesting.
until they have enough competition. So has to be that there's like three different generic manufacturers competing against each other for that
Mm.
market share. And then you start seeing the price coming down.
I would
But
think they would invent super Ozempic so that it'll make the Ozempic, as a marketer, it'll make Ozempic look, or generic Ozempic look like it's crappy.
well, that's what they basically try to do with brand recognition. And that's
Right.
why Novo Nordisk, even though their patent was about to run out, they launched in India, trying to create that brand recognition
Right.
before the generic came out.
Yeah.
And so they're trying to compete, with Lilly for
Yeah.
that's ahead with
Right.
Mounjaro
And
now.
try and make the generic look like it's terrible.
Yeah, and to try to, get people to say, well, I'm going to go for the brand. But when it
Yeah.
comes to the generics are good.
Yeah.
They're normally good quality. They're usually like in our country, the generics are FDA tested,
Right.
and they've been shown to be safe and effective. So anyway, that is a great opportunity to just see more global access to generics.
Right. Especially in India where so many people don't have money.
And Dr. Cooper, it is smart, though, to keep an eye on what's happening in Canada because it's legal, isn't it, for us to order drugs from a pharmacy in Canada?
Well, you're not allowed to order more than a certain quantity and
Hmm.
never for anything other than personal use.
Ah,
So it's like 90 days worth for personal use is the standard kind of adopted kind of rules.
mhm.
Whether they're written out so clearly we're not sure. But if you try to import more than that, or you're trying to do something with it in this country, that is illegal.
Right.
Other
Like
than
you
using
can't
it for
open your own
personal.
pharmacy, Mark.
No.
I wasn't that good in chemistry, so that's good. Well,
I
as we
never
as
took
we
it.
wrap things up, Dr. Cooper, I think it's interesting that GLP-1s are just universally inherently interesting because so many people's lives are being affected by this. What do you think the next big development in GLP-1s is going to be? We've talked a little bit about some emerging drugs, but just
Yeah.
as we wrap things up, what do you think the next big thing is going to be?
Well, I think there's like probably three that are the closest to, where we'll see coming up. One is the orforglipron by Lilly,
That's
which
the pill.
is that's a pill. That's going to be a pill. And what's great is it's a breakthrough medicine. Certain meds are breakthrough meds when they break into territory we've never seen before. So even though it's a GLP-1, the way it's manufactured, it's a small molecule technology, which makes it so that it's way less expensive to manufacture and to ship and to store. And it's easier for patients to take it. It's a pill that's not sensitive to moisture or temperature or food timing. So that will be a breakthrough because we're thinking that it will be much more cost effective, and it's going to be efficacy wise close to the Wegovy, close to that. So the other one that may come out soon is the already available pill form of semaglutide, which is Ribelsis. And that pill is a peptide, so it is more fussy. It's more expensive to make it than the orforglipron. It's more difficult to store it because it's very sensitive to moisture, so it has to be in these blister packs. It's more difficult to take it because you have to take it on an empty stomach. So it's a little more fussy, and more expensive. But what they found was a higher dose than what's currently available was a lot more effective. So they're going to probably relaunch that at a higher dose range than what we've had before. So those would be two oral GLP-1 pills. The orforglipron's a GLP-1, and so is the semaglutide pill. So those probably will be coming out,
And
and
who's making those?
they both will have similar efficacy, close to the Wegovy effect. And what would you say, Andrea?
Who's making those?
Well, Lilly is making the orforglipron, and
Right.
Novo Nordisk is making the other one, the Ribelsis. And then the third one is also Novo Nordisk, I always Cagrilintide. This one is a similar to semaglutide, but also combined with a amylin receptor agonist. Amylin, we've talked about before, is another hormone the pancreas makes in response to food. And it's very beneficial for people that have leptin signaling problems. And so this is going to be combined in one medicine as a weekly injection. So now the amylin was the very first injectable med that came out in 2005. It was the very first one before the GLP-1. So right around the same time as the first GLP-1. And it came out in a short-acting form, so it wasn't that practical to take it. And unfortunately, that one has been discontinued now. So it went off patent. There were no generic manufacturers that took it up, and it's now discontinued, and we can't even get it anymore. So it's wonderful that we're going to have another form of amylin coming out soon in a longer acting form, and I think that will be very helpful for a lot of people with obesity.
All right. Well, we covered the headlines, the latest on GLP-1s around the world. All right. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.